Respected medicos, good morning to one and all. Today we are going to learn about case presentation in surgery MS examination practical. And today the case is of a splenomegaly. So how we should do, how one should perform with a limited time, within half an hour you have to rattle out whatever you have learned throughout your career. So time constraint is very much there and time is very important. So the title is Case Presentation Surgery MS Examination in MS Examination. Myself Dr. G.R. Patel, ex-professor and head of the Department of Surgery. Having teaching experience of 28 years, I had been examiner for MS for many universities. Welcome medicos. We are meeting here today to discuss how a postgraduate should answer in the practical examination. We are discussing case presentation. It's the most important method to assess a student. The candidate is expected to answer certain questions and demonstrate certain signs pertaining to the patient. Today we will be discussing about a case of lump in abdomen of splenomegaly who is almost always kept in the exam. Case presentation by a candidate in 30 minutes. I am presenting a, this is how he presents. I am presenting a 32-year-old male patient named Mukesh Bhagubhai Patel. Of course, the name you can write MBP. The name is not to be disclosed. Belonging to Adivasi community and residing at Chikli, was admitted with the chief complaint of lump in upper abdomen for 5 years with dull aching pain, pain in the knee joint and wrist joint, backache, and frequent attacks of jaundice and fever. He also complained of generalized weakness. He is not feeling energetic. He also complained of dyspnea on exertion. He studied up to 12th standard, then left. His occupation, he works as a helper in ITI Institute. The lump in abdomen, the chief complaints are mentioned in the chronological order. So the first symptoms should be discussed first and other symptoms must be subsequently described. So that is called chief complaint in chronological order. Lump in upper abdomen for 5 years with dull aching pain, pain in knee joint and wrist joint, backache and frequent attacks of jaundice, fever off and on. He also complained of generalized weakness. He is not feeling energetic. He also complained of dyspnea on exertion. He studied up to 12th standard and then left. His occupation is a helper in ITI. The lump in abdomen most likely to be the spleen because spleen is the site for RBC destruction and it gets enlarged. Spleen develops repeated infarct and develops hypersplenism. Then the spleen is to be removed. Dyspnea on exertion, the cause of dyspnea on exertion is anemia because of a hemolytic crisis patient or suffers for many times. So the patient becomes anemic and he becomes dyspneic on exertion. As per the history given by the patient, he is most likely to have sickle cell disease. Sickle cell disease is a genetic disorder transmitted from generation to generation. Past personal and family history, there are repeated attacks of pain, joint pain involving large joints like a knee joint, ankle joint, elbow, and wrist joint. There was history of repeated fever with joint pain and severe body aches, along with the jaundice. Personal history, patient used to pass dark color urine and clay color stool. Normal routine diet, mixed diet patient was taking, vegetarian as well as non-vegetarian. He does not have any habit of smoking. Addiction, occasional alcohol. Family history has one brother, one sister. Sister has some problem of joint pain. Brother has pain. Father is normal. Mother is sickle cell disease. And patient is unmarried. There is no history of bleeding diathesis in any member of the family, any family member. History analysis. What do we get from the history? Patient coming from Adivasi community and residing in endemic area. It is most likely that the patient is suffering from sickle cell disease and develop sickle cell crisis off and on. In sickle cell crisis, there is massive hemolysis and the patient develops sudden jaundice, dehydrated, and may become extremely weak and can go into hepatorenal shutdown. This is a complication, serious complication of sickle cell crisis. And patient might develop thromboembolism of a pulmonary vein and can succumb to the disease. General examination of the patient means head to toe examination and front to back examination, including vitals, TPR, and blood pressure. The patient had blood pressure of 140 by 80 millimeter of mercury. Patient is conscious, cooperative, well oriented to time, place, and person. Temperature is 99 degrees centigrade. Pulse rate is 100 beats per minute. Regular. Blood pressure 140 by 80. These are the vital data. Hairs are normal. Eyes, eyebrows normal. No ptosis. Palpable fissures normal. Unexpected, unexposed sclera is yellow. So for diagnosis of jaundice, it is unexposed sclera is inspected for and taken into consideration. The exposed sclera appears muddy and dirty. So that is not the correct, that does not give the correct information. Pupillary reactions are normal. Pupils are of normal size, bilateral equal, reacting to light. The general examination we are continuing with the general examination. The patient looks cachexic and emaciated. Neck veins not engorged. No cervical lymphadenopathy. Palms, finger, nail, yellowish sting. Both the testes appear normal in size. Chest and abdomen fullness appears in the left hypochondrium. Back and trunk appears normal, no obvious deformity. External genitalia is normal. No spider nevi, no palmar edema, which are the two signs of liver failure. So he does not have these signs. Lower extremities, pitting edema over both lower limbs. That suggests a liver failure or hypoalbuminemia because albumin is synthesized only by the liver. The liver itself is diseased. When spleen enlarges, it advances towards the right iliac fossa. Presence of a notch in the confirmatory sign that the mass in the question is spleen and not a kidney. The movement of the abdominal wall on respiration, if, if present, it certainly rules out peritonitis. So local examination of the abdominal examination is done by keeping the patient in supine position with both the hips and knee joints flexed so that the abdominal wall is relaxed. On inspection, the abdomen, there appears to be a diffuse mass in the left hypochondrium. Rest of the abdomen appears normal, no other lump in the abdomen. Movement of the abdominal wall on respiration, as I said, is present and equal on both sides. That rules out peritonitis. Hernial sites are normal. No visible vein over abdomen. No pigmentation over abdomen. Back and spines are normal. The clinician stands on the right side of the patient for palpation of spleen and starts palpation with right hand towards the left hypochondrium. The palpation is done in a systematic way. The clinician warms up his hands and uses hand sanitizer. Local temperature is measured by touching the patient's abdomen with bare hands. It may be raised in case of peritonitis. First, superficial palpation is done. Guarding may be present. Guarding is the contraction of the abdominal muscles when pressed upon, temporary contraction, and rigidity, persistent contraction. Look for tenderness, that is pain on pressure. On applying pressure with palm or a finger, the patient winces in pain. Tenderness of McBurney's point is the classical example. Renal angle tenderness is seen by pressing over renal angle, this is Murphy's point. Spleen is a part of reticuloendothelial system in which lymph nodes are included. This patient had palpable inguinal lymph nodes on both sides, on significant less than 2 cm, but not significant. Lymph node enlargement is non-significant. Axillary lymph nodes are not palpable. Then comes the percussion of the abdomen is done in the percuss with the fingers. As usual, we are percussing. In this patient, the lump is dull on percussion, and the dullness is continuous with the splenic dullness. There is dullness over the right hypochondrium, and the dullness is continuous with the liver dullness. There is no ascites, urinary bladder is not full. The patient had a palpable lump in the left hypochondrium with the palpable edge of the mass about 7 cm 7 centimeter from the left costal arch in the mid-clavicular line. The edge of the lump is rounded, firm in consistency, and having a notch at the edge of the swelling. The upper border of the swelling could not be reached. The swelling moves craniocaudally with respiration. You should not say up and down. You should say craniocaudally with respiration, confirming it to be the enlarged spleen. There is no tenderness. The swelling is not bimanually palpable nor ballotable. Then deep palpation is carried out to palpate for suspected kidney lump or retroperitoneal lump. Bimanual palpation with one hand over the abdomen and one hand on the at the back. Any deep seated lump could be located. This patient had no other lump in abdomen. Liver is palpable in right hypochondrium 2 cm below the costal margin in mid-clavicular line. Back and spines are normal. So in this patient, liver, spleen both are palpable and they are formed because of a deposition of hemosiderosis. That is why liver and spleen are palpable. Rectal examination was done as a routine procedure. There is minimal fluid in the pouch of the glass. In female patients, pervaginal examination is routinely carried out. Any collection in the rectovaginal pouch is noted and managed accordingly. Present weight of the patient was 45 kg. Then comes so that is about the abdominal examination. Then comes the systemic examination. For respiratory system, normal breathing, breath sounds normal, no bronchi, no crepitus. The nitrourinary system, there is a yellowish discoloration of urine, no frequency of or burning acquisition, no hematuria. GIT system, there is no history of hematemesis. Cardiovascular system, patient feels dyspneic while walking, no chest pain, heart sounds are normal. Central nervous system, the patient is fully conscious, well oriented to space and person. There is no evidence of hepatic or prehepatic encephalopathy. So, case summary, a 32-year-old male patient presented with splenomegaly and jaundice is probably in sickle cell crisis. At the moment, he should be subjected to medical line of treatment and then should be thoroughly investigated and treated accordingly. About the investigation of the patient, routine hematology should be done. Hemoglobin CBC and hemoglobin electrophoresis is a must to know the level of persistent fetal hemoglobin. Blood group, patient might require blood transfusion, so blood group must be decided. Electrophoresis is the investigation of choice to confirm the diagnosis of sickle cell disease. Liver function test, serum bilirubin and SGOT, bleeding time, clotting time, prothrombin time must be investigated. Urine examination routine for bile salts, bile pigment, and stercobilinogen. X-ray test is required. Ultrasonography of the abdomen must be done to look for gallstones, which is a complication of sickle cell disease, and if necessary, MRCP for biliary pathology must be done. This patient management, about management about this patient, will require lifelong management. Administer ingalactate intravenously. This is to make the pH of the blood alkaline. This will decrease the hemolysis. Patient must receive hydroxyurea. The patient must take plenty of fluids throughout the day. Folic acid 5 mg daily to decrease the severity of crisis, and then refer the patient to bone marrow transplant institute. About tips and tricks for management of sickle cell disease. These patients are having low hemoglobin, which keeps the viscosity of blood low, so the sickle cell crisis is prevented. Take plenty of liquids and cited foods. Do not do strenuous work or exercise. You should not get fever. Take all precautionary measures against malaria, typhoid, and any infection which causes fever. Pre-marriage counseling must be done. Take 5 mg folic acid daily. Thank you all. Thank you.